welcome to Fertility Fact or Fiction, one of the best shows on the web for all things related to infertility. We are super excited to be back with you guys today. We have an amazing topic, breakthrough paper discussing the relationship between obesity and miscarriage rate and implantation. So I am really happy to have you all back. We hope that you'll have the opportunity to like, comment, and subscribe. And we are super excited because finally, after a long time, we've managed to get all of the 4 platforms on one camera, so I can actually look at you guys on one camera and not have to look up and down. So great to be with you all. Hope you guys have had a good week. Hope all of you have stayed safe. As always, recently we talk about the impact of COVID, and I want to spend a few minutes, once enough people are on, to chat about this whole concern regarding COVID vaccination and infertility. I think that's an important topic to go over. And I also think it's a really important topic for people to be aware of. Some of you may have seen a bit of a discourse that went on our Instagram account with someone who was clearly anti-vax. And I think it's really great for everybody to have their opinion and everyone to know how they feel about things, but I think it's also really important to follow the science, and we need to make sure that we understand, all of the different elements of what's involved in a fertility journey. Your arm's totally clearly. I know. So anyways, we're working out the glitches with this new system. Make sure, as always, if you like the topic or the show, you like, comment, and subscribe. It's critical for us to get that feedback so we know what we can do better for you and how to make the show better. And thank you to the many partners and other fertility specialists out there who are either watching or doing their own shows. It's really important for us to use this medium to reach out to patients. Obviously, we're all doing our best to help you all. And we've actually had a great opportunity to help countless people from all sorts of different places. Just before the show, I was texting someone from Australia. We have all sorts of people from Ireland. So we have done our best to really reach out, and it's going global, which is wonderful. So I guess we will see what happens with everyone coming on. I suspect that you are going to need to tell me what happens on Instagram, because then none of the comments are coming up here. Yeah, so that might not work. What's that?
I wrote one to you.
Oh, did you? Yeah, nothing's showing up here for sure. So that might be a glitch.
Yeah.
So where will people ask their questions to?
Ask it here. I'm with you.
You can see it there?
Yeah. I'll just keep the window open the whole time.
Okay. All right. Perfect. Okay. So the topic tonight is a topic related to the impact of obesity and the implications for embryo implantation. So what we wanted to do was check out what the relationship is. And in order to do this, it's really important to have a well-done study. So there have been previous studies that have looked at this with actually thousands and thousands of women, both in donor cycles and in autologous cycles, going back into the patients themselves. And they've previously demonstrated that as your body mass index increases, that the chances of success go down and the chances of miscarriage go up. So we kind of knew this data, but there were questions about whether or not it was a problem with the embryo or a problem with the uterine environment. And we didn't know because not all of the embryos in the previous studies had been tested for genetic normalcy, or what we call euploid embryo status. So in this study, what they did was they actually amalgamated or looked at all of the patients that they had from one specific center who had undergone Pgta testing, and then examined those patients only for their euploid embryo transfers. So these are patients who we know have a genetically normal embryo. And then they followed them to see what is the chance of live birth, our sort of gold ring outcome that we're always looking for, and what is the chance of miscarriage, which obviously we want to avoid. And in doing so, they were able to define whether it is a problem with the embryo or a problem with the uterine environment that is leading to the miscarriage rate. So it's a really nicely done study. What do you need for a good study? You need big numbers, you need a well done kind of protocol, and then you need appropriate statistical analysis. So this article is not published yet, but it is available online. and it's from Fertility and Sterility. It should be coming out sometime soon in the next couple of months, most likely next month or the month after. The lead author is Cozzolino, Cozzolino, and the article is entitled Female Obesity Increases the Risk of Miscarriage of Euploid Embryos. So I'm going to share this with you all for you guys to see, and you'll be able to see that, I hope. Tar, can you see that over there?
There's always a lag, so we'll see.
All right. So I'm going to show you a couple tables here and go over a bit of the discussion. So overall, they had 3,480 cycles. And what that had within it were 155 women that were actually underweight. So their body mass index was less than 18.5. They had 2,549 with a BMI of 18.5 to 24.9. They had 591 that were 25 to 29.9. And then in what they classified as the obese category, and this is the international standard, greater than 30, there were 185 women in that category. Their lowest BMI was around 15 and their highest was 44. So the extremes were fairly narrow. We do have women that come in with even higher BMIs, but it doesn't always, work out in terms of fertility therapy. If the BMI is that high, we really just don't even begin. And the risk, that's because the risks are too high. So in terms of the data for this, if you're on Instagram, again, it looks like even with this new software, we can't show you the data, but we're trying. So essentially, the first table just showed that the only statistically significant difference was a very minor difference in age. And we're talking months when I talk minor, which has no clinical significance. And then the only other thing that was significant was the amount of gonadotropin that they needed to use. And because the injectables are fat dependent, because they're going into your adipose tissue, when you have more adipose tissue, you frequently need a higher dose. So in the lowest group, less than 18.5, the average was 2,308 units. And in the higher group, where they were over 30, you needed 2,902 units. And again, these are averages. So there was a statistically significant increase through each group. It went from 2,300 to 2,400 to 2,600 and then 2,900. So obviously that fits with the known aspects of what happens. What's interesting is they didn't see actually a substantial difference in the number of eggs retrieved. They did not see a difference in the modified cycles versus natural cycles for doing the embryo transfers. So that's natural versus where we program it with hormones. Estrogen doses or levels were not very different. The number of days of stimulation was essentially the same. And the number of patients getting Pgta was essentially the same. So it was all pretty uniform in that regard. There was a little bit of data on sperm. They did show that, interestingly, there was a very slight difference in the number of progressively motile sperm depending on the body mass index. It actually varied depending on each age group. It wasn't clinically significant, so I'm not too worried about that stuff. Everything else was the same. You had roughly the same number of euploid embryos in each body mass index, same number of embryos transferred, and it was the same for the rates of embryos that were biopsied on day 5 and day 6. So table 3 is the most important one. And again, if you're watching on Instagram, I'm sorry you can't see this. We have tried, but you'll be able to see it when it comes out. So what they showed is that if your BMI was over 30 and you were comparing it to the group that was less than 18.5, so these are obviously very thin patients, you had a 46% decrease in the incidence of live birth per embryo transfer. So that is huge, right? Almost half the chance if your body mass index is higher compared to the lower group. Now, why is that significant, or how is this data being derived? This is from a logistic regression analysis where they're actually controlling for all of the confounding variables. The variables included things like age, sperm quality, the indication for doing the pre-implantation genetic testing, the type of ovarian stimulation protocol, the type of endometrial preparation, or even what method they use to do the genetic testing with. So regardless of all those factors, you still had almost half the chance when the body mass index was higher. When you compared the greater than 30 to what is considered normal weight, which is 18.5 to 24.9 for your body mass index, 37% decrease in success. Still a huge number, highly significant finding. When you compared greater than 30 to 25 to 29.9, which is in the overweight but not obese category, it was a 38% decrease in success. So still very substantial. So the numbers here are very, very important, because what it's telling us is that regardless of which other category you're in, once you're in the obese category, and they're defining that as over 30, you are at a very, very substantial reduction in live birth, even with a genetically normal embryo. All the other things they looked at in the group had no impact. And those are the things I mentioned to you: the number of sperm, the type of stimulation, what type of Pgt was used. All of these things resulted in the exact same rate and outcome. So when you look finally at the clinical outcomes, they have a lovely graph. And the important thing here is that they were actually able to look at biochemical pregnancies, so the early ones where we just see your beta rise and then, God forbid, fall before you even get to the point where we can do an ultrasound, and clinical pregnancies or miscarriages where we have a live heartbeat or at least see a sac, and then subsequently you're seeing a miscarriage occur. So what they show, and the graph for those of you who are watching on Twitter and Facebook and so on, you can see it on YouTube. This shows that as the weight group went up, you have this very linear increase in the rate of miscarriage. And in particular, the clinical miscarriages are very high when your body mass index gets over 30. It's over double what it is when your body mass index is even in the normal range or the lower than normal range. And it's almost double what it is when you're just overweight compared to in the obese category. So the data from all of this essentially supports the fact that when you are in a situation where you have your body mass index as one element of the concern with your fertility, dealing with that really is very, very critical to your success, because you're looking at anywhere from a 47% to like a 37% decrease in chances when your weight is part of the problem. And what we need to do is make sure that we are taking appropriate care of you to make sure that we are addressing all of your fertility journey, not just throwing you into the IVF grinder and getting everybody to run through it because that's convenient, expedient, or profitable. If your weight is not in the right category, you may need to take a step back and make sure that you do the right things for your health before you get into the point where you need IVF. Now, if you guys have been watching the show for a while, you'll remember that a while back, I think it was probably last winter almost, we actually reviewed a study that looked at the relationship between your age and your body mass index and whether or not it was worth waiting. And there is a cutoff around 38, 39, where you actually start to see a decline in success because you've waited longer and your age is going up, despite the fact that the body mass index may be a concern. So again, we always talk on the show about cookie cutter medicine. We want to make sure that you guys are not, getting cookie cutter medicine approach and therapy. So this is really critical because it's important for you guys to understand that, it's not one size fits all. You may be 40 with an elevated BMI, and maybe the most appropriate thing to do for you is make your embryos with the IVF, bank a couple of embryos or cycles so that you have the embryos ready to go. You're not delaying, waiting for weight loss, but then wait for the weight loss while the embryos are frozen, and then do a transfer when your weight's in the correct category. So there are lots of ways for us to work with you, to collaborate, to get you to where you want to be. but it does have to be done carefully. You don't want to just jump into a cycle, because the reality is that if you do, it may not actually work out to your best benefit. So is it a fact or a fiction that your weight is important even if you have a genetically normal embryo? It is an absolute fact. It is critical for you to understand that your weight has a very significant role to play, even if your embryos are genetically normal. If your weight is higher, unfortunately, you are going to experience a lower chance of live birth, and a lot of that is due to an increase in miscarriages that are occurring, which means it's not something wrong with the embryo, it's something wrong with the uterine environment, the hormonal milieu, your bloodstream, maybe your inflammatory mediators, and so on. And those are things that are modifiable by us helping you get through that part of the journey. So make sure you like, comment, and subscribe. We love having you guys on the show, and we really want to make sure that it's as good a show for you as possible. We'll definitely be back again next week with another topic. And so thank you very much for joining us, and we appreciate you being here. We're going to move on now to doing the remainder of the show, where we always try to answer your questions. So I will have to look at the screen from time to time, and Tarek's got the Instagram questions hopefully there. So I'll start here, and then you can shoot those at me, I guess, as well. Can you become pregnant and have successful pregnancy with polyps? So polyps are growths of tissue inside your uterus. And those tissue growths can actually cause an increased risk of failure and an increased risk of miscarriage. Normally, we tell people it's about a doubling of your risk of miscarriage. So while you can successfully conceive and continue with pregnancy with a polyp, we definitely recommend that they be removed. The removal of a polyp is a super easy procedure. It's very safe. It's very simple. It's generally not harmful at all as long as it's done by an expert. So it's a simple thing to do. I got a lot of highs. At 41, should I only consider IVF? Just had another miscarriage in November. Well, that's a great question. Let me put that one up, actually. So that's a great question. And I think the answer to that is yes and no. So from a medical standpoint, we know that IUI in someone over the age of 39 or 40, number one, should not be done more than 3 times. We reviewed that on a recent show. And as well, has a pretty low yield. So if you look at the ESHRE guidelines, the European Society of Hormones and Reproductive Endocrinology, they basically recommend you do IUI once over the age of 39. And if you are not pregnant from that one try, you should go directly to IVF. It's easy to say in Europe because IVF tends to be socialized medicine over there, so you're covered, or it's not as expensive as it is here. But here or in America, it's a different story because unfortunately you guys are paying quite a bit for this therapy. So I do support the idea of going to IVF relatively quickly over the age of 40. It also depends on a number of other factors. How much, how many resources do you have? What does your bank account look like? Do you have medication coverage? Did you try something before you got to this stage? Have you had previous failures? How many successes did you have trying on your own? And if miscarriage is the problem, have you explored why you're miscarrying? So again, I don't believe in cookie cutter medicine, but I do believe that it's something that should be considered. Definitely don't do more than 3 cycles of IUI. If you can afford to do IVF right from the get-go, it's certainly going to give you a higher yield than the IUI is, but I don't believe anybody should just jump right into fertility therapy. I always make sure I know what's wrong first, and then we start offering you various options, be it natural therapy, vitamin use, increased frequency of intercourse. Sometimes it's real simple stuff. Then moving through IUI and then moving to IVF. So great question. Thank you for sharing that question for us. Big round of applause. And we appreciate having it there. Can't see it on Facebook either. Oh, I guess they couldn't see the share screen on Facebook.
Oh, really?
Or yeah. So that's interesting. Why are scientists and doctors still using BMI? It does not take into account body composition or race. It is arbitrarily putting people into weight categories without taking diet and exercise into account. So Jacqueline, that's a really good point. However, we are talking about norms and general terms. So what you're talking about is, does one racial group have a typically different BMI? And the answer is yes. There are racial differences in BMI, and some of that can be attributed to bone mass, muscle mass, and so on. But by and large, the majority of your BMI is being derived by your overall weight. And the difference in bone mass and muscle mass, unless you're like a bodybuilder or really have a lot of muscle, is not going to be reflected on average in the patients that we can see. So I can definitely tell you in my own practice, it's really a negligible difference in terms of woman to woman based on race, as far as the BMI is concerned. So you're right, there are differences based on race, and that should be taken into consideration. And maybe they can go through this and divide it up by racial background. But it actually does not make a clinically significant difference for us when we're analyzing this in terms of a fertility practice. You want to try one from there?
Hi, doctor. Do you do endometriosis biopsy since the surgery is so hard to do nowadays?
Do I do endometriosis biopsy? So you can't really do an endometriosis biopsy. In order to look for endometriosis, you have to be inside of a woman's pelvis. So you have to go in through the umbilicus or the abdomen, and you got to look around inside. You can do a biopsy once you're in there, but you have to be operating. There is no other biopsy, and certainly a uterine biopsy will not tell you if the patient has endometriosis. There are some commercially available tests that can try and tell you if you have endometriosis. They are universally useless. Do not waste your money on those.
I am 30 years old and had 20 eggs retrieved and 15 fertilized.
That's awesome.
I don't have signs of over hyperstimulation and ultrasound came back normal. Is it okay to have a fresh transfer done?
Oh, so if your estrogen, if you made 20 eggs and 15 were fertilized, you're going to have very high estrogen levels. So the things that are important are how high is the estrogen level, and is your progesterone level okay on the day that they administered the trigger to you? If your estrogen level is very high, it does supercharge your endometrium, and according to the most recent data, it diminishes your chances of success and increases your chances of pregnancy-related complications. We just reviewed that 2 weeks ago. If you have an elevated progesterone level, it will drastically decrease your success rates. So if they didn't check your progesterone level before they did the trigger, and most of us don't, because most of us are doing frozen embryo transfers now, then I would not recommend you go ahead because you may be losing an embryo. Having said that, if you're low risk for a hyperstimulation, they didn't use an HCG trigger, they used the Leucron trigger, and you've been taking your progesterone ever since, and you've got 15 embryos to choose from, or let's say you end up with 10 embryos to choose from, while I never advocate for wasting an embryo, there is a reasonable degree of expectation that you could try and then see, what happens. It's not unreasonable for you to consider using one single embryo to see if it works, but keep in mind you are engaging in a higher risk pregnancy if your estrogen levels are higher.
Massage therapy in first trimester.
As long as it's not deep tissue massage, go for it. There's no issues there at all. Let me take one from here. What about those who are taking care of their health but are still in the obese category? So this is going back to our article from Jacqueline on Facebook. Jacqueline, if you're taking care of your health, you have to be addressing the obesity. So it is not enough to simply say I'm taking care of my health. You must get the obesity part of it down, especially if your obesity is due to adipose tissue excess. If it's just related to muscle mass, then you're fine. But if it is related to adipose tissue content or concentration, then you definitely need to bring that down. You can't really say you're taking care of your health, but then you're remaining in obese category. Every study out there shows that multiple risks are higher when you're obese. Cancer risks are higher, diabetes risks are higher, heart disease risks are higher. Blood clot risks are higher, inflammation, immune system malfunction is higher. So there are multiple risks. So you can't really say you're taking care of your health, but you're staying in an obese category. If you're working on it, that's a different story. But if you're staying in there, that needs to be addressed. Hi, Dr. V. Thanks for answering our questions. You're welcome. Why would my estrogen be 5,000 to 6,000 each IVF cycle, yet I only had 11 and 9 eggs retrieved? I don't understand why my estrogen gets so high. 34 years old, BMI. So your estrogen is formed by cells that surround each egg. They're called granulosa cells. And depending on what the concentration of granulosa cells is and how many receptors and so on they have, that determines how much estrogen you're producing. Now, we typically believe that a reasonable egg makes probably 600 or 700. So you're not that far off with what you've got there. Those are pretty normal numbers based on what we would anticipate for you. I don't think that estrogen is that high. That's a pretty normal estrogen for our values. There is a different unit system for the states. So if you're using those units, that is a high estrogen level for American units. And if that's the case, you either have really strong eggs or there is some other hormonal issue that needs to be looked at. And then Amy's following that up with, here's another one we can show. Whoops, sorry. Does high estrogen during the egg retrieval lower egg quality? So we don't think it necessarily lowers egg quality because egg donors have sky high estrogen levels because we're trying to make them make lots of eggs, and we get great egg quality. I mean, our success rate so far this year has been off the charts for our donor program. So I think realistically, it's not the estrogen causing an egg quality problem, but once you've made the embryo, if you do try to transfer it fresh, it causes endometrial problems. And the endometrium is the main actor once we've got a good embryo. So we need to make sure that we are keeping your endometrium healthy. And in order to do that, you don't want a sky-high estrogen level. You want a reasonable estrogen level, which is why we think that the pregnancies are higher risk and the failure rates are higher. American Amy says, and my eggs are terrible. Amy, you shouldn't have terrible eggs if you're making 11 and 9. That doesn't make a lot of sense. It happens, but it's not common. So we'd have to check into that. I don't know why you'd have bad eggs if you've got very high estrogen levels and you're making 9 and 11. That doesn't make a lot of sense, especially at your age with a good BMI. I would reconsider which lab you're at, and I would make sure that the sperm that you're using is good. It may not be you at all. We see that all the time.
Do you recommend Pgta testing if we retrieve 20 eggs, 15 fertilized,
Nope.
and no previous IVF? Miscarriage, and I'm 30.
No, definitely no. So the question, if you couldn't hear Tarek, is patient's 30, she's never had a previous miscarriage, she made 20 eggs, 15 fertilized, would we recommend Pgt? So there is no study that supports the use of Pgt in your age group. It is absolutely useless to you. For example, we don't do it with our egg donors. Some of our donors are 30. And again, we have sky-high success rates. If you are young and you are healthy and you're producing a high number of embryos, at 30, the maximum likelihood is you're going to have like a 30% aneuploidy rate, which means out of every 3 embryos, 1 is abnormal, 2 are fine. Maybe even less. It could be 25%. So every 4, 3 are normal, 1 is abnormal. Why would you do Pgt? You're exposing the embryos to an unnecessary test that increases your cost, possibly damages the embryo, allows you to get false positive results, and it's not helping you. The STAR trial showed that. We reviewed that on a previous fertility factor fiction show a long time ago, and then a follow-up study of that showed that it was even more significant than what they had said it was. So it is not indicated. The new Canadian Fertility and Andrology Society guidelines are coming out on Pgta, and even they say it needs to be individualized, and there is no good data to demonstrate that it is beneficial for everybody. Certainly, if you're younger, you're making lots of eggs, there is no utility to doing it, and I would argue it may even be detrimental. So do not do it. It is not useful for you at all.
Oh, wow. Dr. Victor, this video quality is amazing. Good job, Tarek.
Big round of applause for Tarek, who got a brand new lens for us, and that lens is awesome. So thank you to Tarek, thank you to Canon, and thank you to all of you for watching, because all of you subscribing and watching helps us grow the show. So the more input we have, the more friends we have watching, the more that we can do with the show. So it's great to do that. And he's got a huge smile on his face, which you guys can't see. He's like a kid in a candy store right now.
So after 3 failed IUIs, should we try IVF? All 3 IUIs, same process, meds.
So if you've done 3 IUI, we definitely recommend changing something. If you watch our fertility factor fiction show from a couple of weeks ago, it demonstrated that if you are doing IUI, then if you are younger, you can do up to 6 cycles and you'll have a reasonable chance of success. And if you are older, and I think the cutoff was 40, then you should do a maximum of 3 cycles and then move on. So it depends on which age category you're in. But if you're in that older category and you've already done 3 cycles, you should change. For patients that are younger and have already done 3 cycles, my question would be, did you do 3 cycles natural? Did you do 3 cycles with pills? Or did you do 3 cycles with injectables? If you did 3 cycles already with injectables, there's probably not going to be as much utility in going on. Now, the study we reviewed did say that it didn't matter. But I would argue that 3 cycles with injectables, there's an emotional toll. There's probably a financial toll if you're running out of drug coverage. And it starts to kind of weigh you down. And then it makes you more skeptical about the IVF process, where we need you to be hopeful, because your stress level, your emotional status actually has a legitimate impact on the success rate of the cycle. So you got to change things after 3 tries. If you're over 40, you should be going to IVF. If you're younger than 40, if you did pills before, maybe consider doing the shots. If you did natural, maybe consider doing the pills and then the shots, but you got to change it up after 3 tries.
Does the male's BMI affect miscarriage risk?
I believe there is data that actually shows that the male BMI increases miscarriage risk, but it's indirect. So men that are heavier have an increased rate of sperm DNA fragmentation for a variety of reasons, one of which is just heat. And so when you have higher sperm DNA fragmentation, your risk of miscarriage is 1,183% higher. And we reviewed that on this show as well. Oh God, it was probably a year ago or so, but it was forever ago. So go back on the YouTube channel, www.youtube.com/drvictory. The video is up on the channel, and you can find it there. And it talks about how high the risks are when sperm DNA fragmentation is elevated. So yes, having men that are obese is a significant risk factor for complications in pregnancy, as much as having a woman that is obese is. Let me take one from here. I am 39 and will be looking into IVF in the new year. Does it make sense to implant 2 embryos to increase chances of success as Pgta recommended? That's a great question. So if you're 39, Pgta is recommended. However, if you are doing Pgta, we definitely don't recommend putting in 2 embryos, because the chances of twins is very high, and pregnancies with twins have much higher risks. So we definitely recommend you not do that. About a year and a half ago on the show, we had a study showing that if you consecutively put in individual embryos, you actually end up with a higher chance than putting in 2 at a time. So we definitely are big fans of elective single embryo transfer. The only time I put in 2 at a time is when age is a significant factor, and we're talking like over 44, 45. Patients want to just have 2 kids at once and get it done. And or when somebody ahead of time froze them in pairs, because thawing them and refreezing them is not a great option. Have you seen a irreversible case of fertility with heavy steroid use under 40? This is about testosterone suppression caused from 3rd grade varicocele in young patients. So if you took testosterone therapy for a long enough time, you can permanently shrink your testicles, and it can be irreversible, yes. Bodybuilders have frequently learned to incorporate HCG into their testosterone regimen, and that can kind of protect you. But I've actually had a number of very large bodybuilders come in through here, including a couple that were quite famous, and they had terrible sperm performance. So if you are a bodybuilder, you've been taking steroids, you need to be very, very careful because it may not be possible to get you to produce sperm. One last one. What is your recommendation for low AMH and high FSH, like 21? My recommendation for patients with diminished ovarian reserve is do not spend a fortune doing normal IVF because it won't work. So I don't encourage people to do that. I do like doing things like natural cycle IVF, where we're just trying to make you make one egg. It's a reasonable approach to things. It's cheaper, less drug costs, less invasive. I like doing duo-stim, where we do the 2 back-to-back cycles. That's been proven to be beneficial. Maybe not for an FSH of 21. That's probably more natural cycle. And I like trying IUI because at least it's inexpensive and it's worth a shot a couple of times. And then if it doesn't work, you can move up to something more aggressive. Ultimately, what you need to consider is where to draw the line in the sand. IVF can be very addictive. We get a lot of patients that want to just keep spending money, and the hope to be successful isn't there. And unfortunately, not every fertility specialist or clinic is that scrupulous, and they will take your money if you are willing to offer it, even if your chances are slim. So you do need to advocate for yourself. Unfortunately, I hate the fact that that's true, but it's true. You need to make sure that your fertility specialist has explained your chances, explained what the risks and benefits are, and so that you know what your outcome is going to be. I posted on Instagram a couple weeks ago that a recent study from Israel demonstrated that if you came out of a fertility clinic over the age of 41, the women were over the age of 41, they came out of a fertility clinic and they were told in the clinic that they had a 5% chance of success with IVF. They were questioned after they left the clinic and asked, what do you think your chances of success are with your next cycle? And the answer was 49.3% on average. So they were told 5% and they're thinking in their head 50. So unfortunately, because you're so caught up in the desire to have a child, sometimes patients are either not listening or we're just doing a bad job of explaining that the success rates are not that high. And so if you have a really high AMH, you have a really low AMH or really high FSH, what you need to understand and take away from that is, unfortunately, and I'm not saying it to be disrespectful or be hurtful in any way, you have a very low chance. Does that mean you shouldn't try? No. If you want to try, by all means try. But what you need to know from it is your chance is not 50%. It's going to be 5%, 10%, 15%. And if you're comfortable with that number, then go ahead. But if you're going into it thinking my chance is 50, then we have failed in educating you about what we're actually trying to tell you. And make sure you get that information before you go ahead. So that's a brave question. Thanks for sharing that. Lots of likes for you. I appreciate that. And as always, maybe some others can comment and say what they think. Should we have cutoffs for where we do this? Should we have cutoffs for where we tell people no? My personal opinion, I don't think I should have a cutoff for people. I let people decide, but I'm very honest about what I tell them so they're making an informed choice.
Is IUI or laparoscopy more successful? 35 years old, secondary, unexplained infertility, sperm count, good.
So is laparoscopy more effective than IUI in secondary infertility? Probably not. It would probably be IUI that would be more successful, unless you have signs and symptoms consistent with endometriosis, in which case that's a different story. So just doing a lap because you have secondary infertility with no explanation, you're probably going to get a bigger bang for your buck, so to speak, with insemination, unless you live in Canada where you don't pay for the surgery, in which case you're getting a bigger bang for your buck with the surgery because you have to pay for the IUI and you don't for the surgery. The one thing I would caution you about there is there are risks with surgery and there are virtually no risks with IUI. So that's a great question. My hat's off to you for that, but you gotta kind of weigh out the risks and benefits of that one. So maybe some of the people out there that have done it can comment. What did you guys experience when when you had that choice? Did you go for surgery? Did you have a positive outcome, or did you go straight into IUI? And why did you do it if you chose one or the other? Let us know. We'll share that with our viewer. You got another one?
Oh, yeah. I've developed cysts following an IUI cycle with injections. Is it safe to try naturally this cycle while taking a break from IUI?
Oh, yeah, totally. Yeah, cysts don't do anything to you and they'll go away. And now that we have our designation as an out-of-hospital premises, we've actually started draining cysts for people. So if you've got cysts and they're hanging around more than a month or two, it's totally worth it to come in. We'll try draining them. It doesn't always work, but it's a reasonable shot. We just did one this weekend, actually, for a young lady that has been trying and her cysts wouldn't go away. So no harm in trying on your own, but there's also no reason why you can't get it dealt with without having to have surgery. Just conscious sedation, poke a needle in there and drain it.
What is the total cost of IVF, both natural IVF and medicated one?
Okay, so I can't speak to that in general. I can only tell you what our charges are because I don't know what everybody else's charges are. I know that if you're in the US, it's about 2.5 times what it is here. Here we're pretty inexpensive, and I think we're one of the lower ones in Canada. So we charge $6,000 Canadian for everything you need except your medications to do natural cycle IVF. We charge about $9,995 for everything you need except your medications to do standard IVF. Duo stim, where we're doing 2 back-to-back cycles for women with weaker ovaries, is $16,288, not including the meds. And then we do offer live baby guarantees for people that qualify, and that's just over $22,000. And that includes the meds. So those are our prices. It's totally up to you which one you choose. You do have to kind of find which category is right for you, and I often help with that. For example, someone that can make lots of eggs shouldn't really do natural cycle unless they have a religious objection to freezing embryos, in which case it's a great choice. Conversely, someone that has really weak ovaries should not be trying to spend 10 grand on a IVF cycle when they can get away with 6,000, because you can spend 10, spend another 5,000-6,000 on meds and still only get 1 egg. Why not just spend 6,000 and maybe 500 on meds, get 1 egg, and then take all that money you would have spent for the meds and the rest of the cycle and just do another cycle? You're going to get the same outcome with way less stress and hassle.
I'm 4.5 weeks pregnant, and I have
Congrats.
had 1 miscarriage earlier this year.
Okay.
I have very slight pink discharge given in vaginal canal,
Yep.
but no spotting and burning backache.
Yep.
Do I need to worry about miscarriage?
Well, everybody needs to worry about miscarriage and not worry about it. I mean, obviously there's nothing you can do. So you should be getting your beta HCG done and then 48 hours done again. It should rise by a minimum of about 60%, and you should follow up with your doctor. So even at 4.5 weeks, we'll know if the pregnancy is appropriately going up or down. Let me take one over here. My husband is on Clomiphene and has 0 sex drive. Is this common? No. Actually, we use Clomiphene in men with low testosterone to help make more testosterone. So that's not common. Great question. And thanks for being brave enough to share, but that is not common. So I would get his testosterone checked, make sure he's not obese, make sure he's not smoking, drinking, using drugs. And then sometimes, as much as we don't think about the guys, guys can be a major issue. So guys deserve the same care and attention and TLC that the women do. So maybe he's having a stressful time with this. Maybe he feels like he's failing. And maybe that's adding to the stress and kind of creating a vicious circle or cycle. So ask him, talk to him. Communication is always the key. It makes a big difference. Fertilization rate, 64% first IVF ICSI, 33% second IVF ICSI, first round, one abnormal blast, nothing second round. I can't wait for our consult with you next month. Antagonist first, antagonist second, 34-year-old, husband 46. Amy, I can't wait to talk to you too. You've got lots of good info and questions here. That fertilization rate needs to be improved, so we got to figure out why that's happening. I will let you know. Does the maturity of the follicle change the chances of success during IUI, or do all mature follicles give the same odds? Well, if they're all mature, then they should give you the same odds. If they are post-mature, it will not give you the same odds. And if it's immature, it won't give you the same odds. But if they're mature, they're an M2, you should be fine.
How many milligrams of aspirin should be taken before a transfer?
81 daily.
What are your thoughts about progesterone suppositories? As effective as oil progesterone?
No, progesterone suppositories have been proven not to be as effective as oil. So we use both. We always use oil and we use the progesterone suppositories together. Think about it this way. Progesterone is probably a paracrine and an endocrine substance. What does that mean in English? It means it works by getting into your bloodstream and affecting various parts of your body, and it works on nearby tissues, being the uterus. So it is important to get it to the uterus and to get it into your bloodstream. You cannot get a high enough concentration of progesterone in your bloodstream by inserting it vaginally, which is where the oil comes in. And conversely, the oil may or may not get a high enough level into your uterus. That's why we use both with tremendous success. Our FET success rates, frozen embryo transfer success rates right now, are incredibly, incredibly high. The highest I've ever experienced, even when I was working in my previous IVF center. We are doing amazingly well with our protocol. We do use a specialized protocol. You can always message me. I'm happy to share. We use a lot of natural approaches. We use natural substances. We make sure everybody's perfect. And then we go for it, but it is working extraordinarily well for us. And of course, we do an amazing transfer. My immense gratitude to Dr. Khosravi, our incredible embryologist, who has done amazing wonders with our embryos. So, amazing thanks to her. And we love you, Fariba, if you're watching. She's probably exhausted from the day's work.
How do you decide which blastocyst is the best one to transfer?
So I actually don't decide. The embryologist decides which blastocyst is the best. There are different grading schemes, but the grading schemes all are based on what the embryo looks like as a whole, and then what the trophectoderm portion, which is the part that's becoming the placenta, looks like, and what the blastocele portion, which is the portion that's becoming the embryo, looks like. So those are the parts that they grade, and they grade it based on how uniform it is, how granular it is, are there large vacuoles and things like that in the embryo. So it's a morphological score, and that's how they choose. There are a lot of current technologies going into computer-based algorithms that will kind of score your embryo based on what's called morphokinetics. So you put the embryo in a time-lapse incubator, and then you watch how it develops through the incubator, and then you apply some kind of algorithm to it, and everybody's got one they think works, and then it tells you this one's better than that one. None of them have been proven to be beneficial yet, although there is some hope coming from that kind of thing, but so far it's not really that useful.
Can I insert vaginal suppository while standing, or must I be laying down? If yes, do I need to stay laying down for a specific period of time? When I get up,
no.
I feel the progesterone all weekend.
So that's a great question. So the question is, if you're inserting progesterone, can you do it standing? Not sure why you'd want to, but maybe it's because it's at work. Or do you need to lie down to do it? So progesterone often comes in a form, like vaginal progesterone, that has a vehicle and then the progesterone. The vehicle is what is delivering the progesterone, and oftentimes it comes out. So if it's crinone, it's that gummy, gluey, jelly kind of stuff. If it's prometrium, it's like a light creamy goo. If it's a vaginal suppository that's custom compounded, it's always a goo. And then if it's endometrium, you get that gush of fluid that comes out. So there's always going to be something that comes out, but your vagina is actually incredibly absorptive. So if you are putting it in and you're getting it even remotely high enough, like an inch or so into the vagina, you're going to do fine, and you don't need to worry about whether you're standing or sitting. Don't worry that some of it's coming out. The heat of your vagina is melting it. The progesterone's absorbing into the walls of the vagina, and then your vehicle is what's coming out of you. Good question. What supplements do you recommend to improve sperm quality in a 46-year-old? No smoking, no drinking, no drug use. Tons of fertility vitamins. We use YAD. They have 3 different kinds for the guys. And we also use ProFertile, which is Health Canada approved, specifically indicated to improve sperm quality. And not just that, but sperm DNA fragmentation. So it's a great product. We're kind of switching to them in some senses. They're great. And then make sure you're exercising. Make sure you are eating very healthy. If you're obese, bring your weight down as quickly as possible. Keep your testicles cool. So sit on frozen peas for 20 minutes a day. For God's sakes, don't feed them to anyone. And that's probably about it. Ejaculate every 2 days minimum. Should I take one? Or you got
a million. I don't know if you'll make it.
Oh, you got a million. Let me do this one. Over 3 IVF retrievals, I have had 39 eggs retrieved, 25 fertilized, and of those that the doctor let go to day 5, none have survived the blast. Oh my God, Caitlin, I'm so sorry. We have severe male factor and suspected egg quality issues. What approach would you recommend? The first cycle was Menopur, Gonal-F, and Orgalutran, and then added in Omnitrope and Lupron daily starting the month prior to the subsequent 2. We've had success with a day 3 transfer, but also 2 miscarriages. Wow. I would recommend that, number 1, you don't go to day 5. You're a good case where a day 3 embryo transfer might be reasonable. It may do better in you than out of you. I would recommend you spend a lot of time improving the sperm quality if possible. That's a huge issue. And I would recommend you make sure that you are working with an embryology team or individual who really knows how to pick good sperm. So that can be very critical. Not all labs can do that. And so that's very, very important for you. If your embryologist is just firing away with the sperm because they're busy, you're not going to get a good result. If you've got someone that really cares and is spending the time to do it, then that's going to give you a much better result. And so in that regard, a smaller center will do better than a big center will. They just can't handle the volume, and they're very busy, so it's kind of rapid fire. Whereas in a smaller center, you may be the only case that day or one of 2 or 3, and so the embryologist has the time to sit there and do the job. So make sure you take the right approach. Yeah, give me one of your million.
Do you tell patients after a transfer that they can still pick up and carry their kids? Will lifting my toddler cause a miscarriage or embryo implantation failure?
Yeah, we don't love it when you lift toddlers. So God gave them those chubby little legs to run on. So let them run, and you can sit down and have them come to you and kind of pick them up. But I wouldn't strain immediately after. Having said that, after 24, 48 hours, you're probably perfectly fine. Don't be heavy lifting, but picking up your toddler is fine. Mommy needs a hug. Daddy needs a hug. It's all good. Baby needs a hug. So that's okay.
Are cysts possibly related to your eating and weight? And can I get rid of them by eliminating foods?
No, you cannot get rid of your cysts by eliminating foods or your weight. Polycystic ovarian syndrome can be partially corrected or treated by losing weight, but not ovarian cysts. If you have a dermoid or an endometrioma, you can eat super healthy for the rest of eternity. It's not going to go away. It's in fact going to get bigger. So cysts do not go away with diet or exercise or anything like that.
Interestingly, I heard that Israel offers free fertility treatments. Is this true?
As far as I understand, healthcare in Israel is socialized. They actually have an amazing healthcare system there. So I do believe it is free there. Don't quote me because I have been to Israel many times, but I've never asked what the healthcare system is like. But I'm sure I could find out.
Is IUI a good option for someone with very low AMH in their 20s?
Advice for someone? Is that what they're asking for?
No. Is IUI
a
good option for someone with very low AMH in their 20s?
Yeah. So like I said, anytime you have low AMH, regardless of what your age is, IUI is an option because IVF is not going to give you a high yield in terms of the number of embryos that you get. So that's critical because if you're not getting a lot of embryos, you might be investing $10,000, $15,000 into it, and you might only get one or two. And if they don't work, now you're out 15 grand, and we haven't done you necessarily any favors. So I actually am a big proponent of IUI for those patients because at least it's cheap. And if it doesn't work, you can always re-explore the IVF option or donor egg option or whatever option you want. But keep in mind that in women with diminished ovarian reserve, this is another fact or fiction we looked at, and I think I actually did it in a Instagram post. Even a 6-month delay in treatment actually makes no difference, or up to 6-month delay in treatment makes no difference in your outcome. So you can delay your treatment by 6 months and still have a decent outcome even when your ovaries are not working as well as you want them to.
Can high emotional stress experienced by a woman cause embryo implantation failure?
Yes.
Or a miscarriage?
Miscarriage, probably no. We don't know. It's kind of hard to quantify stress.
Perhaps a future fertility factor fiction.
Yeah, so stress actually reduces success rates by up to 60%. There are studies that show that. So we want you not stressed. That's why we have the amazing Brenda Davies, Darcy Thachuk. We've got our lovely Dr. Jennifer Strong, who's great at relaxation, acupuncture. We got a chiropractor that we use, Randy Mayrand. She's amazing. A family doc that does counseling for us, my beloved friend, Carrie Mayrand. Yes, they're sisters, the two Mayrands. We got all sorts of people to help you. We've even got an addiction specialist. So we want to do whatever you need to make this work for you, and reducing your stress is a big part of that. We also have our online program, Organic Conceptions. And I got 1 minute left because I think we start, what did we start, 8:59? Yeah, 8:59. We got a minute left or two. So let me take one from here.
I got at least 20 questions.
I can't get to everybody. What are the pros and cons of Letrozole versus Clomid? Is it possible to respond to one more than the other? So there's a head-to-head trial in the New England Journal of Medicine by a guy named Legro, Legro, where he showed that 6 months of Letrozole for women with PCO has a 27.5% live birth rate compared to 19.1% for Clomid. So first-line therapy is Letrozole, not Clomid. Having said that, there are some people that respond differently. What is the cost of Pgta testing? It varies depending on what we're doing for you and how many embryos you have. Minimum around $1,800, maximum kind of sky's the limit. We charge $1,800 for the biopsy, but then Cooper Genomics charges for assessing it, and we just charge you whatever they charge us. We don't charge anything extra. I think we got to wind it down, man. One more quickie?
You want me to pick one, or you want to just go in order?
Pick one.
Random pick. Here we go. Hello. Okay, not that one.
Quick.
So I started fertility treatments 3 years ago at 22. Now I'm 25. I had one miscarriage with IUI and moved on to IVS. First transfer failed, second one miscarried. What should I do?
You need to find out why you're having miscarriages at such a young age. So you need what's called a recurrent pregnancy loss workup. Your fertility specialist should be able to do that for you. If they refuse to do that for you, find a different fertility specialist. Okay, guys, 8:58. Oh, we still got 1 minute, you think?
I got more if you want more. That last one could be, last.
Quick.
Okay.
It's 8:59. See if you get cut off.
Do you tell patients they can get up immediately after the embryo transfer, or they
No,
lay down for a few minutes?
We tend to ask them to lie down for about 10, 15 minutes. So with our patients, we keep them lying down for a little bit. Are you still on?
My AMH has 50.6 last month. and this month 38.5.
Yeah.
Is this reason for concern?
No, your AMH is sky high, so there's nothing to be worried about. Don't worry, you're fine either way. That's probably lab error. So you're still going strong, eh?
You're still going
I'm
strong.
still going strong. All right, let's take one or two from here. What are the... Nope. Here we go. Hi, doctor. I have a question. I was diagnosed with complex endometrial hyperplasia without atypia, and now doctor started me on prometrium. Can I still get pregnant? Okay, so you're on the wrong medication. You should be on Megace or Megestrol acetate, and you need to be on it for 3 months, and it is probably the strongest birth control possible, or at least one of the stronger birth controls possible. So no, you will not be getting pregnant now, but you can't get pregnant now because you have a precancerous condition in your uterus. What causes poor egg quality other than age? Smoking, drinking, marijuana, low vitamin intake, chemo exposures, chemicals, plastics in the environment, genetics. It stopped recording. What else? Obesity has a big impact. Excessive thinness has a big impact. And then multiple conditions like autoimmune diseases, inflammation, endometriosis. There's loads of things that can do it.
Shit, I'm just on the safe side.
Yeah?
You're still going, but you'll just cut out at this point.
I was told by yourself that having babies would lower my risk of having my breast cancer return. Could you explain more? Sure. There's good data actually that shows that women that have had babies after breast cancer live longer and have lower recurrences. So it's just research based. I can send you the studies, just reach out to us, but there's data out there and I've reviewed it with our cancer center. So pregnancy is salutary, meaning beneficial for women that have had breast cancer.
Got a lot. You want me to go or you want to stop?
Let's give them another 5 minutes because some people never get their questions answered.
Okay.
Fire away.
My mom's period stopped when she was 42. I'm 31 and my AMH is 34.7 pmol per liter. Is a guarantee that I will also reach menopause early as my mom did?
No.
Is menopause genetic?
Menopause age can be genetic, but you've got a very strong AMH, so it's highly unlikely you would go into an early menopause. You can certainly keep an eye on it by having your AMH checked, but I wouldn't be worried about it at all.
Dr. Victory, tea or coffee drinker? What's in the mug?
Green tea. I don't think you could see the tea bag without me drinking it. I only drink green tea. Antioxidant. In fact, I buy this Tetley brand that actually says antioxidant on it. I've gotten Tarek to drink it too. I only drink green tea. It's like good for cancer fighting. So this is good stuff. And I actually just had my own DNA tested by Invitae to see if I carry any cancer genes because I suspect I do. So I'd like to know so I can start getting screened earlier.
I use vaginal suppositories with my successful first FET. So can I use vaginal suppositories again, even though oil is more effective since it worked for me the first time?
Yeah, so I mean that's a great question. If something worked for you before, I'm certainly not going to tell you to reinvent the wheel. So my first rule is if it ain't broke, don't try to fix it. So it's really hard for physicians to learn to sit on our hands, so to speak, where we don't do something, but it's actually a really good thing to do a lot of the time. So if the patient's being perfectly fine on one protocol, don't mess with that protocol. Just leave it alone and do the same thing again.
Why would an embryo not survive the thaw process?
Bad freeze, bad thaw, bad embryo. So it's going to be one of those three.
All right, good job reading the question.
Tarek is taken to giving himself a little pat on the back there, ladies and gentlemen. He claims he's being faithful to the text here. So he's.
This is the last question I got.
Okay.
Endo with reoccurrent implantation failure.
Yeah.
How is this best approached?
Get your endo treated surgically. Take 3 to 6 months of Luperon and Letrozole. use a low dose estrogen approach and during your FET, and then you should be good to go. But get it surgically treated. That's the best thing to do. Okay, last one over here. Hi, Dr. Victory. Is it normal to have 2 periods in a month? 100% no. So you should not have 2 periods in a month. You should only have 1 period every 21 to 35 days. And if it's not 21 to 35, you need to get checked to figure out why. So 2 periods in a month is not normal. Okay, I think this is the first show in like a year. We actually got through them all. Do you still have 1 million, or are you done?
You have no idea how good you look on here.
Okay, Tarek's become fully delusional, folks. So listen, amazing show. This was really fun. I hope you guys enjoyed it. Thank you so much for the great comments and for the feedback. Make sure you like, comment, and share. It's really important to us. And give us your feedback about your experiences during the show. So if someone says something, we want to hear from you guys. What was your experience with that? How did you feel about it? Because I can put that stuff back up there, and that really helps everybody else too. So huge shout out to everyone involved here. Thank you all for attending and watching. We love you all, and have a great night. Stay safe. Please, please, please wear your masks. Don't believe people that are talking about anti-vax and anti-mask and all that stuff. Oh, I did promise I'd talk about vaccination. So I said this last week. I'm going to say it again. Some lunatic out there has claimed that the COVID vaccine is going to render you infertile. This is what we refer to as rubbish or nonsense. So the COVID vaccine is targeted, at least the first one from Pfizer, is targeted to one of the segments of the spike protein on the virus. The spike has a code of amino acids, and 6 of the amino acids on the spike that are not related to where the actual vaccine is targeting are similar to 6 amino acids in a row that are on a placental protein, a placental cell protein. So the individual claimed that this is going to render all women infertile. Well, that's total nonsense. So first of all, the initial study had something like 43,000 men and women in it, and none of them have reported that they're infertile. That's number one. Number two, women with COVID, the actual virus, would have been rendered infertile by their own immune system coming up with antibodies to it, and none of them are having trouble. They're not even having miscarriages while they're pregnant or any kind of pregnancy complication above and beyond what happens to you because of COVID, like pneumonias and cough and so on. So this is just total crazy nonsense by people that don't know what they're talking about and are trying to spread misinformation. I am not encouraging you to go run out and get the vaccine. That's a choice you get to make on your own. But what they are saying is not true. So if you're not doing it because you're worried you're going to be infertile, there is absolutely zero evidence to support the concept that the vaccine is going to render you infertile. And scientifically, it doesn't even make sense. So I would not worry about that whatsoever if that is your concern. Certainly, if something comes up, we will inform you, and I watch for this stuff every day. No one is reporting any such thing like that whatsoever at all. Have a good night, guys. We look forward to seeing you in person. We look forward to talking to you online, and I hope you enjoyed the show. Take care. Bye now.